Live.
Good evening, dear friends. I, Dr. Ajit Shinde, President of Maharashtra Orthopedic Association, welcome you all to this innovative MOA Masterclass webinar series. Today we are inaugurating new series on a challenging topic called pelvic acetabular fractures. And today's session will be deal with part 1 of these fractures, the elementary fractures of acetabulum. For this program, today, Sunday evening, we are fortunate to have established renowned masters in this field of pelvic acetabular surgery as an expert panelist. I welcome today's dignitaries starting from Professor Dr. Mohan Desai, Department of Orthopedic, KIM Hospital, Mumbai, Dr. Mahesh Kulkarni and Dr. Atul Patil from Pune, and my friend Dr. Dinesh Kale, Professor of Orthopedic, Belgaum Medical College. And our convener is young dynamic orthopedic surgeon Pradeep Nevade. We are going to witness now the various case scenarios which these experts not only have faced but also successfully managed with their skill and wisdom, which is gained over many years of practice. As a hip joint being such an indispensable part of everyone's day-to-day activities, proper reconstruction of this elementary fracture of acetabulum holds immense importance, eventually deciding quality of one's life at the end. So let's now hear all the tips and tricks from the masters themselves, which I think no one should afford to miss. So without wasting any time, I request Dr. Pradeep to carry forward the proceeding. Thank you. Jai Hind, Jai Maharashtra, Jai MOA.
Thank you very much, sir, for the nice introduction. So, in today's program, we are going to have first two talks. The first talk would be two orientation talks. I would be speaking on the column concept and how Letournel has used this column concept for classifying acetabular fractures. And Dr. Atul Patil is going to go through the algorithmic approach, how we are going to basically classify each injury according to the algorithm and put him into their respective classification group. After that, we'll have few case presentation and case discussion, and we'll be taking any questions that are put online for discussion as well. So I'm going to start with the uh, classification.
Unmute Pradeep.
I hope my screen is visible.
Yes.
Okay, yeah. So uh, studying the acetabular column concept and then the acetabular fracture classification. So if we see acetabulum embryologically is made up of three bones, three ossification center, one for the ilium, one for the pubis, and one for the ischium, and they slowly ossify to form an adult pelvis where they fuse in center. The triradiate cartilage, so-called triradiate cartilage, fuse to form an acetabular structure like this. So this shape is basically pretty weird, very difficult to describe what shape the pelvis bone is, and that is why it is called as an innominate bone. We cannot put a really any name to this shape of the bone. And so broadly speaking, we have this ilium bone, we have the ischium bone, and this pubis bone. And at the juncture of that three is the cavity that is placed is called as the acetabulum. So broadly speaking, if we see the acetabulum from the lateral side and medial side, uh, this part of the bone which uh, constitute the SI joint, and from there a solid strata bone goes down towards the acetabulum, is called as the sciatic buttress. So this is a very strong bone of the body, and this basically connects the rest of the pelvic structure to the axial skeleton. So from the sciatic buttress, we have short stocky appendage that goes down posteriorly like that, and that is called as the posterior column. And then we have a long, slender, kind of a conical structure that goes anteriorly, and that forms the anterior column. Just just a minute. Sorry for that uh, interruption. Okay, so if we see the pelvis from anterior and posterior side again, we can see that the long slender column which is very broad laterally, and it cones down anteriorly to form the pubis. That's the anterior column. And a very short stocky posterior column that goes from the sciatic buttress towards the ischium. So in general, this forms a kind of a Y like a structure, and at the juncture of the Y is the acetabular cartilage that has been placed. So this is a basic column concept that has been put forward by the Letournel, that the acetabulum has two columns, the posterior column and the anterior column. There is a small outpouching of each column which contains the femoral head. So it's respectively it's called the posterior wall and the post anterior wall. And we have this part which connects these two columns to the axial skeleton, that is called as the sciatic buttress. So this is in nutshell the acetabular, the Letourneau's column concept. So, if we see radiologically, and we are going to see it in detail in the next talk by Dr. Atul Patil, acetabulum radiologically impart four lines. The first line that goes from the ilium goes towards the pecten pubis, also called as the iliopectineal line. Another line which goes from the ilium and goes towards the ischium medial margin is called the ilioischial line. So iliopectineal line is roughly the anterior column, ilioischial line is roughly the posterior column. If we trace the lower margin of the superior pubic ramus like this, that line is basically the anterior margin of the anterior wall, and a line which we trace the outer aspect of the ischium, that line is basically the posterior wall. So that's the iliopectineal line, that's the ilioischial line, that's the anterior wall line, and that's the posterior wall line. So knowing these lines is very important, because we are going to see how breakage of this line and permutation combination of breakage and intactness of this line will help us in putting the fracture in their respective groups. Okay. So based on this, Letournel classified acetabular fracture into 5 elementary group and 5 associated group. So elementary group, if you see there, the fracture line is a single, confined to a single area. Sometimes they can be combinated, but they are confined to the single area. So suppose the entirely fracture lines are confined to the anterior wall, then it's called as the anterior wall fracture. If all fracture lines are confined to the posterior wall, then it's called the posterior wall. If the fracture line involves the entire anterior column and rest of the structure remain intact, that is the anterior wall column fracture. If the fracture line separates the posterior column from the rest of the acetabulum, then it is called as the posterior column fracture. Transverse fracture is in general basically, though it traverses both column, but the fracture line is single, and that's why still it is included into elementary fracture type. It basically divides the pelvis into the superior ilium to inferior ischiopubic fragment. So it's a very simplistic fracture line that divides the pelvis bone into two parts, and it's called as the transverse fracture line. Then we have the multiple permutation combinations of this fracture line, which gives us associated fractures. So if you see, there are two fracture lines in each fracture group. Sometimes there can be even more than that. So that we are going to discuss in the part 2 of this series. Today we are going to focus entirely on the elementary fractures of the acetabulum. So this is a typical posterior wall fracture. So now if we see the though there are multiple fracture line and comminution, the entire thing is confined to the posterior part of the posterior wall part of the acetabulum. So the rest of the acetabulum is intact, anterior column is intact, posterior column is intact, but the posterior wall is badly comminuted. So this is a posterior wall fracture. So that is how the posterior wall is fracture is seen. So if you see from the medial aspect, the pelvis remains intact. From the posterior aspect, we see the posterior lip that is in fractured and reflected up. So this is there are three components of this posterior wall fracture. So this is the wall fragment. These are the impacted fragments, and these are the loose intra-articular fragments. And these are how they are going to be seen on the CT scan. So we can see that the lead fragment seen away from the acetabulum. Then we have the intra-articular fragment like this, and then we have the impacted fragment that is seen aligned like that. So that is how different fragment can be seen. And at the lower section, acetabulum was going to seen intact. Typical mechanism of injury is the dashboard kind of injury where we have posterior directed force in a flex hip like that. So that's the force vector. The entire force get concentrated on the posterior wall of the acetabulum, and posterior wall breaks, and that is how posterior wall fracture is being is resulted. So we have either a typical fracture that is going directly posteriorly, or we can have a posterior superior fracture, or we can have a posterior inferior fractures like that. So it they can occur because of different position of the limb. If it is hyperflex, then it will result into the posterior inferior. If it is little bit extended, then it will result in the posterior superior. A 90-degree flexion will result in the typical fracture of the acetabulum. And depending upon the abduction adduction also, we can have different type of fracture. If it is too much adducted, we'll have pure dislocation or a very marginal chip of the posterior wall. If it is at neutral position, then we have a posterior wall, and if it is abducted, then we can have central fractures like transverse or T fracture that may be associated with the posterior column. Again, presentation can be either with the dislocation or without the dislocation, and sometimes we can have no impaction, or sometimes we can have lot of impaction. So impaction is a very important feature that are associated with the posterior wall fracture, and that we need to keep in mind, and we're going to see this during case discussions and all. Sometimes it's very important to know the pattern of soft tissue attachment also. So we can have a total loss of soft tissue attachment on the posterior wall. But the most typical presentation is that posterior wall is separated, but it is attached with a capsule. Sometimes we can have intermediary fragment which have attachment only of the retroacetabular soft tissue, and these fractures like this, which are articular fracture, we do not have any soft tissue attachment. They are just impacted and aligned with the head path of the femoral head escape. So special forms such as extended posterior wall fracture, where we can have the fracture that is going from the 12 o'clock to almost 6 o'clock position, or we can have a horizontally extended fracture where the fracture is going horizontally towards the sciatic notch. So these are the horizontally extended fracture like this. So these are the horizontal extended, or sometimes we can have a very extended fracture which can take even the sciatic notch. But since the obturator foramen remains intact, they are still classified as the posterior wall fractures. Transitional fractures such as undisplaced transverse fracture may be associated with the posterior wall fracture. Since the transverse fracture is undisplaced or incomplete, they still will behave like a posterior wall fracture and can be classified as a transitional form between transverse with posterior wall or a posterior wall fracture. Another part is called as a pure superior form, where there is a pure superior fracture where here the fracture line goes and exit into the iliac crest. So it's very atypical to classify this into posterior wall. However, we cannot put it into anterior wall or anterior column because the iliopectineal line is intact, and since the obturator foramen also intact, it is not any part of the posterior column as well. So it is basically a pure superior form of the posterior wall fracture. So it can be called as a superior wall fracture, but it seems there is nothing called as a superior wall. they are being put for classification purpose into a posterior wall fractures. Coming into posterior column fractures, posterior column fractures look like this. Here the entire posterior column gets separated from rest of the acetabulum. So we can see that here the posterior column that has been separated from the rest of the acetabulum. The entire column remains intact. The fracture line starts from the inferior pubic ramus, traverses through the pulvinar of the acetabulum, and exit at a various region into the sciatic notch. So that is the posterior wall. So this is the separated part of the posterior posterior column. This is the separated part of the posterior column. The force factor is little bit more center. The point of impact is little bit more center than the posterior wall. Posterior wall point of impact is much more peripheral and towards the wall. Here it is more towards the center of the hip. But since it is directed posteriorly, the entire posterior column breaks like that because of the force factor. And these are the typical subgroups. So this is a typical fracture which exit into the basically vertical limb of the sciatic notch, and the fracture line goes starts at the inferior pubic ramus. Sometimes we can have an extended form where the fracture line going very much medially, in fact almost going into the iliopectineal brim, and the fracture line can exit at very high level. Sometimes it can even exit at the superior margin or horizontal limb of the sciatic notch. So these are the extended posterior column fractures. We can have a partial superior form where the fracture line is limited only to the superior part of the acetabulum, and instead of the inferior fracture line going into the inferior pubic ramus, it exists at the ischium, and the obturator ring is broken, but inferior pubic ramus remain intact. So these are the special forms. So it is again a transitional form between posterior wall what we have seen, but here key element to know is that the obturator ring is broken, and that's why it has been classified into the posterior column and not at the wall. So this is the feature which we have seen in the last talk, that sorry, last group, that is the posterior wall. These two fractures look similar, but here since the obturator ring is intact is the posterior wall, and here since the obturator ring is broken it is posterior column. Sometimes we can have a partial inferior form. So the fracture line starts from the inferior pubic ramus, goes through the acetabulum, but do not traverses very high. It goes and exit at very low margin. So it's called a partial inferior fracture. So these fractures are very notorious because they also involve some part of the quadrilateral plate, and there is a very bad comminution there. So though the fracture looks simplistic here, they can sometimes have very poor prognosis. Anterior wall fractures. Now anterior wall is the area which lines there basically contain the entire part of the, it's a part of the column but is a segmental part. So here the fracture line starts from the superior pubic ramus, traverses through the acetabulum and exits just above the acetabulum. So here if you see, the inferior pubic ramus remains intact, so it is just a segmental fracture of the anterior column. So that is what is called as the anterior wall fracture. Here the force vector is much more anterior, that is if the hip is at 50-degree external rotation, the force that is traversing through the neck is going to get concentrated on the entire part of the acetabulum, and that's going to cause anterior fracture of the acetabulum. So that is what is the schematic presentation, how the anterior wall fracture can result. So that is what the anterior wall is, a very simplistic or very small part, a cheap fracture, but sometimes we can have a segmental fracture, which is in fact more common form of the anterior wall fracture. Another fracture is the anterior column fracture. Here the fracture line starts at the inferior margin, at the inferior pubic ramus, goes up, traverses to acetabulum, and exit at various places supraacetabular region. So the key distinguishing part between anterior wall and anterior column fracture is the fracture of the inferior pubic ramus. In anterior wall fracture, inferior pubic ramus remain intact. In anterior column fracture, inferior pubic ramus is broken. So that's how we can see that the fracture line is starting at the inferior pubic ramus, traverses to the acetabulum and goes high. In this case it is looking incomplete, but it can exit at various places and can be complete also. So here the hip external rotation is not much, it is only 25-degree external rotation of the hip, and the force that is getting concentrated on the entire column part, and the entire column gets separated. So based on where the superior fracture line exit, there are four subtypes. So if it is exiting at the level of acetabulum, it is very low. If it is exiting just above the acetabulum at the AIIS, it is a low type of a fracture. If it is exiting at the ASIS, it is the intermediate, and if it is exiting at very high, at the iliac crest, then it's called as a high fracture. Now, key difference here, key to note here is the part of the pure superior form of the posterior wall which we have discussed. So this marked part is that special form of posterior wall which we have discussed is a pure superior form, where the fracture line is starting from the iliac crest but do not go down, it exit at the level of acetabulum. So this marked part is actually a pure posterior wall, but if the fracture line goes and traverses through the acetabulum, then it becomes the anterior column fracture. A transverse fracture is a fracture where the single fracture line traverses from anterior to posterior, that is from the anterior column to the posterior column, and it divides the pelvis into two parts. So if you see here, this is a simplistic fracture line divides the pelvis into the superior iliac fragment and the inferior ischiopubic fragment. So that is the blue mark is the ischiopubic fragment which remains intact. There are no break into the inferior pubic ramus. So that is the transverse fracture line, and above part is the iliac fracture line. So this fracture line can be different uh, as per the morphology of the as per the orientation of the fracture line. So that's how the fracture line can be seen, depending upon, so it is in the 2D CT, it is seen going from anterior to posterior because the fracture line is oblique, and that's how it goes. And so it can be transtectal, juxtatectal, or infratectal. So based on this, there are different kind of fracture mechanism which we will not go into the details of this. The force vector is much more center. So associated fracture patterns which are going to see into the next talk. So I will limit my talk at this point, and we're going to go for the classification by Dr. Atul Patil, and then we'll come back and see the case discussion. Hello, hello, hello.
Hello. Hello.
Yes, sir. Go ahead.
Okay. Very nice introduction to column by Dr. Pradeep. That has made life easy. And now we'll see about how to classify these fractures on X-ray and CT scan. Classification about Judet and Ludetl has divided classification in basic as well as associated or complex fractures. As we know, there are five basics: posterior wall column, anterior wall column, and transverse. And if you can see, again, it's a repetition, but it is necessary. So this is a posterior wall. When a posterior column is involved along with the inferior pubic ramus is posterior column. Then comes the anterior wall. Then the column where the inferior pubic ramus along with the anterior side is involved is anterior column, and the transverse which runs from front to back is transverse fracture. Then there are five complex types: posterior wall and posterior column. It's one, number 6 that you know. Transverse with posterior wall. This is a transverse, and transverse plus it verticality, it goes into the inferior pubic ramus, and obturator foramen is broken. And then anterior wall, posterior hemitransverse, and bicolumn, where you have to take a help of CT scan, and both column has a spur sign which is visible, which is a detached part of the acetabulum which is not connected to axial skeleton. So when this is present, then that is considered as both column. So on X-rays, you have to see 6 lines or structures to find out what is gone wrong with the acetabulum. The first one is teardrop, second one is dome line, third one is posterior wall line, iliopectineal line, ilioischial line, and anterior wall line. So all these fractures lines are seen on simple anteroposterior view, obturator view, and oblique view. So if you see the AP, this is a iliopectineal line in which you can see that anterior column is intact. If you see this on the right side, the anterior column here line is broken, and here you can see that anterior column is broken. Then comes the anterior rim, which is always it is in association with superior pubic ramus. Mostly you have to see the inferior side of the superior pubic ramus, and you can see the anterior wall. And if it is broken, then you can see the discontinuity in anterior wall line. Similarly, ilioischial line runs from greater sciatic notch, ischial spine, and to the ischial tuberosity. If this line is broken, it indicates that there is breakage of posterior column. Then comes the posterior wall line, which is in continuation with inferior pubic ramus or ischial tuberosity. And if it is broken, you can see that the posterior wall is also broken. And the teardrop, where the teardrop is here, the teardrop is in center. And if the teardrop is displaced, that you can see that the head is migrated medially. And lastly, the dome, that is a weight bearing area. And if the dome is intact, and if the dome is broken, then you can very well see that breakage of the superior dome. So by taking all these lines, we have to see the two other views, that is obturator oblique and iliac oblique. The obturator oblique, where you will see the obturator foramen in completely, and on which you will see iliopectineal line and a posterior wall line. So obturator oblique will give you a diagnosis of anterior column fracture or a posterior wall fracture. Similarly, the iliac view, where the entire ilium is exposed and seen, where you will see ilioischial line, and this is superior pubic ramus and the anterior wall line. If these are broken, so it is a indicative of posterior column and anterior wall fractures. So coming to this, with the these 6 type of lines, we have to identify 10 fractures. So the most important line is iliopectineal line. So whenever you see either pelvis AP, or you see iliac view or a obturator view, first thing to see always in any X-ray is iliopectineal line. If iliopectineal line is intact, that indicates complete anterior column is intact. So it is all posterior. Either it is posterior wall, posterior column, or it is posterior column with wall. Then next thing you have to see is ilioischial line. So we know that ilioischial line indicates posterior column. And if it is intact, still there is a fracture, then it is a posterior wall. And if there is broken, then it can be posterior wall and posterior associated with posterior column. Now coming to the next scenario, when you see a broken iliopectineal line. So first you see a iliopectineal line which is broken, then it says that the anterior involvement. So where are the anterior involvements? The anterior involvement can be anterior wall, anterior column, transverse with posterior wall, T, anterior column, posterior hemitransverse, or bicolumn. These are the fracture where anterior column involvement is present. So going further, you have to next see ilioischial line. Ilioischial line is intact, means there is nothing posterior, all anterior. So what are those? Those are anterior wall and column. And if you see that pubic extension and obturator view in pubic obturator foramen involvement, if it is present, then it is anterior column. And if there is no involvement of iliac body or a pubic extension, then it is anterior wall. Now coming to the scenario where first iliopectineal line is broken, then ilioischial line is broken. Now you have those two lines are broken, then you have transverse with posterior wall, T, hemitransverse are bicolumn. So these are the 5 types. Then comes you have to see obturator ring. If it is intact, then it is the fracture line is going across, that is transverse. And if it is associated with wall, then it is transverse with posterior wall. And if obturator ring is broken, then you have three types remaining. That is T, hemitransverse or bicolumn, which again you have to see a spur sign which is absent. Then it is hemitransverse or T, or if it is present, then it is bicolumn. So considering only iliopectineal line, ilioischial line, obturator ring, and the spur sign, you will classify all 10 types of acetabular fractures. So coming to the examples where you can see, this is a pelvis X-ray where for you it is given uh, all 10 types here. So coming to the X-ray, you can see the iliopectineal line is first you have to see is intact. That means anterior involvement is not there. Then you can see ilioischial line is intact. So this becomes pure posterior. So this becomes a posterior wall fracture. So no involvement of iliopectineal line or ilioischial line. So those both lines are intact. Next fracture, where you can see this CT scan is given, because you have sometimes you will see a bad X-ray, then you may see a good CT scan. So you can take help of both CT scan as well as X-rays to classify the acetabular fractures, where you can see first always iliopectineal line on both sides it is intact. There is something seen here on the right side. So you go posteriorly and you see ilioischial line is broken and the posterior wall is broken. So here, according to this chart, iliopectineal line is intact, ilioischial line is broken, and there is a posterior wall. So this becomes transverse. This becomes posterior wall with posterior column. So this becomes posterior column with posterior wall. So coming to the next example, here you have to see the anterior involvement. So iliopectineal line is involved. So you can see the anterior breakage. So forget about posterior. So pure posterior is out. Posterior wall is out. Posterior column is out. Posterior association column wall is out. So remaining seven types. Then next you have to see ilio. Next you have to see is ilioischial line. Ilioischial line is also broken. Next you have to see obturator foramen. For you can see the obturator foramen is very well maintained. So it is a pure transverse fracture. And along with there is a small wall fracture. So transverse with posterior wall. Where you will see breakage of anterior line, breakage of posterior line. So both lines are broken. So pure posterior is out. Then pure anterior is also out because posterior ilioischial line is broken. Then you have to see a obturator foramen which is intact. So hemitransverse, transverse, and bicolumn is out, and there is a wall fracture. So this becomes transverse with posterior wall. Another example where you can see a breakage of anterior iliopectineal line here as well as here, breakage of iliopectineal line, breakage here. So no anterior, no posterior. So and breakage of obturator ring, and the fourth is spur sign. So whenever you see spur sign, then it is a bicolumn fracture. So iliopectineal line broken, ilioischial line broken, obturator ring broken, and the spur sign. So this becomes bicolumn fracture. So four things we have seen and diagnosed that this is a bicolumn fracture. What is bicolumn? That this part of acetabulum, which has an articular surface, is free from axial skeleton. It is not attached to the sciatic buttress, and it is not attached to the sacrum and the spine. Another example, you can see iliopectineal line broken here, ilioischial line broken. Then there is a breakage of obturator ring, and there is a free fragment that is spur sign. So this becomes bicolumn. This is CT scan for you. breakage anteriorly, breakage posteriorly, the free fragment of acetabulum, and a posterior wall. So this is a bicolumn with posterior wall. This is a variant of bicolumn fracture. So iliopectineal line broken, posterior ruled out. Ilioischial line broken, transverse or transverse with posterior wall, and T or hemitransverse or bicolumn. Then you see obturator ring broken, yes. So then transverse is ruled out. And then you see a free ilium, that is spur sign, and posterior wall, that becomes a bicolumn fracture. Coming to the example where now you can see the iliopectineal line is broken here, and no ilioischial line is broken, so it is pure anterior. So this becomes an anterior column because it is going from iliac crest to the anterior column. We'll go back again. Here there is no breakage of ilioischial line, but the iliopectineal line is broken. Obturator ring is intact, and on the CT scan you can see the high exiting anterior column fracture. So friends, if you take this algorithm with iliopectineal line and ilioischial line and obturator ring and the spur sign, you will able to classify all your 10 types of fractures, which is very important to know about the geometry of this type of fractures, whether it is stable, it is unstable, whether it is dislocated, medially subluxated, define the fracture line, and then most important thing, you will able to decide about the approach, what approach to be taken for this fracture, because algorithmic approach is completely different. You have to change the position, so it is better that you know to begin with what type of approach you have to take. Thank you. Hello.
Hello. Yes.
Ah,
Hello.
hello. Yes.
Yeah. Okay. Thank you, sir. Thank you very much for that algorithmic approach for classification. I now invite Dr. Dinesh Kale, Dr. Mahesh Kulkarni, sir, and Dr. Shinde and Dr. Sandeep Biraris to be a part of the case-based discussion. What I'm going to do is I'm going to present some cases or a part of a case, basically, just to highlight certain important things in the management of this the elementary fractures of the acetabulum. Okay, is my screen visible?
Yes, yes.
Yes.
Okay,
Yes. Yes.
okay, okay. So this is the first fracture. He was a young male, around a 30-year-old male. He has a fracture of the acetabulum. He had a posterior fracture dislocation which was reduced. Unfortunately, the X-ray is not shown here in this thing, but he has a fracture that is incomplete transverse fracture, as we have spoken about that the transitional part of the fracture. This incomplete transverse fracture is not going entirely.
Small part is going on.
Yeah, small, yeah. But what we are more focusing here is mainly on this comminuted posterior wall fragment. So this is the posterior wall fragment here. So Atul sir, can you please highlight in this thing, in this fracture? Of course we need to see the X-ray. X-ray is not here, but on this two images, can you highlight
So,
what things we can decipher from these two X-rays?
so for me, it is a posterior column fracture and posterior wall fracture
Mm-hmm.
that is visible. A
Mm-hmm.
small two-dimensional CT scan shows an anterior chip fracture, but it is incomplete.
Mm-hmm.
So, uh, posterior wall, which is comminuted, and if you see a two-dimensional CT scan, there's a large chunk of posterior wall which is a derotated and impacted. So there is an impaction is there, and comminution is present. So two things where we have to take care of. So this is an impacted fragment which is highlighted. Actually, that has to face towards the femoral head, and it is now 90 degrees rotated. So we have to take care when we are fixing the posterior wall, not just, I will say it's a extra articular surgery or an intra-articular surgery. So first you have to do an intra-articular surgery where you have to derotate the articular surface to the femoral head, and then do an extra-articular surgery where you have to fix all these wall fragments, maybe with buttress plate and a spring plate and an additional column plate.
So I think that is very well highlighted by Atul sir, that whenever we see this curvature part like this actually the dense part is a subchondral bone which has been rotated, and it's make the path for the head. The head is exiting like this. So when it goes like this, we can see here also that these fragments are oriented like that. The entire flower pattern is like been it opens up and goes posteriorly to make the way for the femoral. Yes.
So for my friends, it is very important always see a two-dimensional CT scan. It is very good to see a very good, nicely given a three-dimensional CT scan, and you find out, ye karna hai. So that is for extra-articular surgery. If you miss on this two-dimensional CT scan, then you will never have a good congruous hip.
Okay. So, Kulkarni sir.
Yeah.
Sir, regarding the management for the posterior wall fractures, there are multiple things that we talk about. Always the posterior wall size, the impacted fragment, examination under anesthesia, or whether it is presenting with dislocation or not. So can you, sir, please highlight all these points which are being highlighted here for the decision making?
Yes, Pradeep. So basically, you need to see the posterior wall fracture as has been seen in this case. It has small fragments, comminuted fragments, several fragments. If you see the axial CT scans as been shown in this picture, you need to first understand how much is the depth of the acetabulum. So from the quadrilateral plate itself, as you can see, to the edge of the posterior wall. So calculate that depth of the posterior wall and see how much of the depth of posterior wall has been taken away by the fracture. In the example that Dr. Pradeep is just now drawing, you can see a significant amount of posterior, more than 50% of the posterior wall buttress is missing. And with marginal impaction, I think this becomes a fracture or an essential fracture to be fixed. Otherwise, the hip remains subluxed and unstable. So we've discussed about instability. So if you have a posterior wall fracture, which does not go, say, for more than 30% of the depth of the posterior wall, in those cases, I think you need to consider examination through a range of motion under image intensifier with the patient awake, and take the hip through a range of motion. And if you feel that the hip, if the patient feels apprehension as you take the hip to say around 60 to 70 degrees of flexion, adduction, and slight internal rotation, I think that becomes an indication for surgery as well, when the patient feels apprehension that the hip might start dislocating. Impacted fragments, big intra-articular fragments, I think again are crucial. They will make sure make you take the decision for operative fixation. So unless and until the posterior wall fracture is only involving the lip, where the hip has not been dislocated and there are no intra-articular fragments or marginal impaction, those are the only cases which could be managed conservatively. Otherwise, all of the other indications, I would take them in total for decision for surgery for posterior wall fracture. Anything else missed out, Pradeep? Or?
Yeah, sir, one thing, suppose a patient has a very small marginal chip, patient presented with dislocation, we reduced it, but after seeing the CT scan, patient has very small marginal, maybe say some 10-20% of the fracture, but he has presented with the dislocation. So now there is a controversy whether to operate this fraction or not. So what is your take on this, sir?
I would personally if the fragment, if it's only a dislocation with only maybe a marginal rim fracture, I wouldn't personally consider fixation.
Yeah.
But you can throw light on the recent literature. I would conserve it.
Yeah. So I think, sir, almost all of us will conserve. Most of the people nowadays it is been seen that we should see them as a labral tear, and
Yeah.
if the patient presents to us with a labral tear, otherwise we will try to fix it. So whether this labrum with the bony attachment shall be fixed or not. So nowadays people are advocating to fix it, but as you said, most of us would try to treat it non-operatively in, at least in our part of the country, that we try
Pradeep,
to. Yeah. Yes, sir.
Pradeep, it all depends on what the patient's profile is.
Yeah. Yes. Correct.
Because as you said, it is a labral tear, and now for a small 2 mm, 3 mm labral tear, they are putting anchors,
Yeah.
and you are leaving 1 centimeter and 1.5 centimeter fragment away.
Yeah.
I just beg to
so,
differ, Atul. The shoulder joint is a shallow joint,
yes,
and actually there is no rim which is left there to contain that shoulder, the humeral head.
no,
Whereas,
I am not saying about the shoulder fractures. The hip scopies they are doing.
okay.
Yeah. So if the patient is before their 40s, hip scopists are pretty aggressive about hip labral tear. And now if the same patient lands up with a hip scopy guy, he would say it's a bony avulsion of the labral tear with bony fragment. So it's
Bony
just
cut.
so just a different way of looking at it. So they would fix. But most of us, we know that most of the patient is anyway going to get good result even with
Yes.
conservative. So we are more inclined toward this. I have treated 1 or 2 patients like this with surgery, but I don't know whether the surgical results would be much more
Is
better than the
overkill.
conservative.
Yeah.
Yeah. So, Dr. Dinesh Kale, sir, of course, we are going to treat this fracture by the KL approach. So, can you give us tips and tricks regarding the sciatic nerve or a greater or exposure, so as to improvise on whatever we are doing right now? Hello.
Can you see me?
Yes, sir. Yes, sir. We can hear you. Yes, sir.
Okay. Normally, when we are doing the KL approach, if there is no sciatic injury during the pre-operative stage, one doesn't need to go and separate the sciatic nerve, but one needs to at least feel and see the sciatic nerve. Once you are retracting the superior inferior gemelli with the obturator interest and take the whole flap back, it acts as a door to cover the sciatic. Second thing is, it is always good to cut the gluteus maximus tendon, so the stretch on the nerve is also prevented. However, if there is a primary injury to the sciatic nerve, one must make an attempt to completely visualize the sciatic nerve so that you can document it. If there is a laceration of the hematoma around that nerve, that has to be documented. Now, coming to the posterior wall fragment, if it is a very high wall fragment extending slightly towards the anterior aspect, it is always advisable to do a GT osteotomy so that your spikes which are going to retract the glutea do not overstretch the superior gluteal nerve.
Yes, sir. So regarding the limb position, can you give us some highlights about how to prevent the sciatic nerve with respect to the limb position? Generally, what we do is we operate in a lateral position, and the hip tends to flex a lot. The knee tends to go anteriorly, and that can put some stretch on the sciatic nerve, especially when your retractor is in
The
the
hip should be
foramen.
extended and the knee should be flexed.
Yes. So as sir has made a point, the sciatic nerve runs from here like this. So the best way to keep the sciatic nerve relaxed is the hip should be extended and knee should be flexed. Uh, One of the problem that can occur is that when the assistant give the longitudinal traction, they give it the knee extended, and that can again create some problem. So one thing is that we need to give traction to the neck of the femur by putting the shank spin there. And if at all we want to give a longitudinal traction, it should be given with the knee flex position.
Yeah, if one is doing a prone position, then this is facilitated by keeping the knee flexed.
Flex, yes.
Automatically, the hip is extended in a prone position.
Okay, so this was the picture when we opened this thing, sir. So we can see that the cartilage fragments are placing, and there were few fragments that were intra-articular and that they were removed. Of course, we are going to elevate it and put this back. Atul sir, how will you prognosticate this fracture at the end of the surgery?
So if you see the analysis of results of acetabular fractures, the worst fractures are transverse with posterior wall and then follows the posterior wall fractures, and it is because of impaction and cartilage delamination. So here if you see a cartilage, whatever the posterior wall is there, which is delaminated, so it will not survive, and some cartilage is lost its softness, subchondral bone. So I will put it across the patient that you will have high chances of post-traumatic osteoarthritis. So I will inform him and take a written consent as well.
Also, if there is a etching on the femoral head,
yes,
then the prognosis is still worst.
So this is the way this fracture was actually treated. We try to elevate, so we try to keep the subchondral bone attached to osteotomy below it, and we try to align all these fragments. Of course, that is what needs to be done. How much it will survive is up to the time will decide that. So we need to put some bone graft as it is being shown in the diagram, and we fix it now and hold it with temporary the K-wire, and then we fix it with the plate. So this is the way plate can be contoured and put. So now, since these patients, there's a high chance that they may require fixation post, THR later on. So how will you do a THR friendly fixation, Mahesh Kulkarni sir? So suppose we know that now this patient has little bit poor prognosis, may require THR, and we are keeping that in mind. So while fixing acetabulum, what precaution we need to do that our future THR will become easier in that case?
So, Pradeep, is this about the posterior fixation you're talking about?
Yes, same case.
Yeah, in those cases, I mean, to be honest, I would try and fix the fracture the best way that I should be, without actually worrying about what will happen in the future, whether I want to go back into do it totally. But saying that, I would make sure that the screws that you put in the posterior wall, you make sure that you are not placing them inadvertently intra-articularly. That is the first principle for any posterior wall, any acetabulum surgery. The second thing is the screws that are in the ischium. You need to make sure that you're directing them away from the acetabulum, as well as the supraacetabular screws should be directed away from the acetabulum as well. So make sure that your screw placement is such that when you come back for reaming, you should not have to remove the plate or the screws as much as possible. Very rarely, there are the lag screws which need to be taken out, which may be outside the plate, and they're easy to remove. So as you've shown here, avoid screws in the area, in the retroacetabular area, as Dr. Pradeep has shown. You can place screws in the inferior and superior part, but again, as I've said, away from the acetabulum itself, and make sure that you don't place inadvertent screws into the joint, which is obviously known to everyone.
Kale sir, regarding the superior gluteal nerve, can you tell how to basically how your plate should be so as to avoid injury to the superior gluteal nerve? Because we know that the superior gluteal nerve takes origin at the the sciatic notch and goes somewhere here like this. So, hello, yes sir.
Yeah, hello. Yeah.
So superior gluteal nerve, which takes comes out of the pelvis at the angle of the sciatic notch and goes somewhere like here. So
Correct.
can you tell us the tips and trick how to prevent injury to this nerve so as to our THR become easier later on? Because it's a disaster if the superior gluteal nerve gets injured.
Now, if you are directing the screws The only problem will come if you are using a cup in which you are going to introduce a screws on top. But usually you get enough space to introduce that.
We are talking about the plate, sir. How, when we are talking putting the plate, how to avoid injury to the nerve, basically.
No, if you are putting a plate, that's why I said you will have to get enough retraction to see the trajectory of the screw. And that is why here the GT osteotomy is very important.
Yeah. So that's a very important point, sir, that means that we have to have a very low threshold for doing the GT osteotomy. Suppose we are having some trouble in putting this screw. If we retract too much, we may inadvertently injure the superior gluteal nerve, and by that we'll burn the bridge of future THR. Another way of doing it is, I think, we can contour the plate rather than going straight. So we have seen many times the plate is in place like this. And then if we put a straight plate like this, again that can endanger this. So inverted J-shaped plate, if we put, so that plate again will help us not to avoid injury to the superior gluteal nerve. So if we put the plate in an inverted J manner like this, rather than putting a straight plate, that will avoid our injury to the superior gluteal nerve, which runs like this. Okay, Atul sir, can you tell us how to make this spring buttress plate, or how to use it? What will be your indications of using and tips and trick of using a spring buttress plate for this?
Spring buttress plate, whatever case you are showing is the best case for using at least 2 or 3 spring plates. And I can prepare most of the times with simple 1/3 tubular plates with a plate bone cutter. You can make 1/3 tubular plate into a spring plate. Otherwise, the spring plates are also commercially available by Synthes, but they are costly. And these, whatever is the seen on the slide right now, is very effective method of putting spring plate.
So same was done for this patient. We have used 3 spring buttress plate, and then on the top of that we have tried to put a plate away from the joint, so that in case he requires joint later on, we can do it better. So anything else anybody wants to highlight about this case before we can move on to the next case? Shall I move to the next case, sir?
One small thing I would like to highlight here is, once you are removing these pieces, try to take the paper cover of the gloves, keep it on the table, draw a diagram of the acetabulum on that, and try to place those pieces from whatever position you have removed them. This will help you a lot during reconstruction back, because you will have a rough idea of how you are going to solve the jigsaw puzzle if there are 3-4 pieces. And please preserve as many pieces as you can. Do not throw away those pieces. They are far better than taking a bone graft and reconstructing the wall.
Yes. So sometimes it becomes very difficult after we have taken it on the table. We don't know what is the orientation. So that's a very good point that you have made, that we can draw it on a paper then and there. So it will help us later on to put them back. Okay. So this is the next case. Sorry for the wrong numbering. It's in the case number 2. So he was around a 50-year-old, 50-ish male, very hefty fellow, had a RTA and had this kind of injury where the head has gone inside the acetabulum. There was fracture of the quadrilateral plate and a proximal femur fracture like that. So this is the sorry, I don't know, I don't think so the video is running there, so let me skip through that. So we can see here on this diagram, so we can have this anterior wall kind of fracture, and the head is going through the acetabulum like this. Atul sir, your way to go for this case. So
go back to X-ray again. Okay, so now to the CT scan. Okay, it has perforated like a quadrilateral plate, and also,
sorry, the video is not playing, so I'm going to skip through that.
Okay. Yeah. And there is a big anterior column fracture as well.
Yes.
And I want to see that there is nothing posteriorly.
So there is nothing posteriorly, means we can see the X-ray also. The ilioischial is intact. Yeah.
So in this, view, the X-ray, iliopectin is also looking intact, but we need Jude views to comment on. But the CT scan very well shows that there is a breakage in iliopectineal line and there is a breakage in a quadrilateral plate. So this is an anterior column fracture along with quadrilateral plate fracture. And the approach here I will take is the anterior approach. It can vary ilioinguinal or a combination of stopa and iliofemoral.
So, Mahesh sir,
Yeah.
what are the tricks to reduce this,
And to
or
fix
what would be,
and to fixation, to before that, I have to take care of the proximal femoral fracture.
Yeah.
So I will first take care of lateral femoral, upper femoral fracture, fix it, and then I will go for the acetabular fracture.
Okay. So so what would be your sequence? Means how basically how easy it would be to reduce this femoral head back into its place out of the joint?
So intraoperative use of shunt spin.
Introverted.
Yeah.
Yeah. My sir, you are a sequence of for this case.
Yeah, I think it will be nearly impossible to fix the femoral fracture unless the head is delivered out of the acetabulum.
Yes.
So one could consider, actually, this is a rare case, but you could place him on a fracture table itself, like you would do for femoral nailing. And in the same position, one could consider starting the approach for the acetabulum. The approach of choice for me is an ilioinguinal approach, but I think you people are probably much more ilioinguinal combined with the stopper through the medial window, and then use a shunt spin from the lateral side to draw the head out, reduce the quadrilateral plate, anterior column, do the temporary fixation or complete the fixation if the head is completely delivered out, and at the same time proceed with the femoral nailing in the same fracture setup scenario.
Kale sir. Hello.
Yeah.
Yes, sir. So,
Yeah, probably I would agree on the lines of what Mahesh has said, but I would seriously still make a first attempt to put a shunt pin into the
Head and neck.
Head and neck and try to pull it out.
Yeah.
If I succeed in that, then my stopa approach to flip back the quadrilateral plate would be much easier. However, easier said than done. If it doesn't occur, we will have to go ahead and do as Mahesh said. I'm not very sure whether we should take this patient directly on a fracture table. Probably I will not take him. I'll take him on a fracture table without the traction applied. Because if you put him on the fracture table, the tendency for the proximal segment is going to sag down. And that might make the life little difficult. So put him on a simple table like a fracture table, keep the leg attachment ready, but do not tie his leg and leave it free in the air. That's my personal perception.
Yeah. So, and another way of basically not taking on the fracture is that the limb need to be flexed if you want to do some ilioinguinal or a stopa approach, and that can also cause a problem if we take it in a fracture table. Is it like that so?
You are asking me?
Yeah. Yes.
Yeah, see, once you take this patient on a fracture table, that limb is totally unaccessible to you for any movements. And at that stage, if you want to do any movements so as to give a traction, then it becomes very, very difficult. You can easily pass a shunt spin even on a simple supine position. Try to pull it out. If you're able to retrieve it out, I would probably go down, finish the quadrilateral side, finish the anterior column side, and then come out to fix the trochanteric fracture.
Having said this, sir, means Letourneau itself has basically advised to take patients on fracture table. We have never been comfortable with it, but based on literature, they have advised to even for normal acetabular fracture, they are doing it on a fracture table. Somehow, I find it very difficult to do it on a fracture table.
No, there are fracture tables where you can still continue to have the complete support still kept on the fracture table. That means your leg is not free. Your buttocks, your thigh, your knee, and your tibia is still resting on a flat top.
Yeah.
For me, there is a plan A and plan B. So plan A, I will take this patient in lateral position, open reduce the proximal femoral fracture, put two good shunt spin or two thick threaded KYS, and using a T handle, I will get that in. As CT scan shows that it is nothing behind the neck. So it is just gone in. You just need to take it out. So I will mostly I will succeed in taking that head out, fix ilioinguinal or stopa and iliofemoral.
Okay. So
Or then whatever the hard way is by whatever fracture simultaneous open reduction.
yeah.
But then if you have to open the acetabulum on fracture table, it is a nightmare.
So
Because mobilizing your vessels is very difficult on fracture table because you need a hip flexion.
Okay, so of course those tables are not available with us, but Western people, they are doing on fracture table. Unfortunately, we don't have those table where we can have that kind of the possibility where we can flex the limb or keep it in that position with the traction on.
Second thing, what I'm scared is if you pass a shank spin and try to pull it out, if your shank spin comes out with that force, then you have lost the purchase. So it's better that you put a shank spin and you push and pull. That means you pull on the neck and you push from inside. That probably will be more helpful.
Yeah, but that is what plan B is that. So you should
Because
not be in very adamant that I will do this way only.
What I'm saying, even in a routine case, sometimes when we have passed our shank spins into the neck and we are trying to pull out, the shank spin walks out, and then you create 1, 2, 3 tracks, which is bad for the neck.
Then there is no option like simultaneous exposure.
So what I did was actually the real question was whether to pull or whether to push. So initially I thought that if I can try pushing it out by stopa approach, because the head is staring out through that. If I can try to push it out of the stopa approach, then I can complete with the acetabular thing, and then I can put the patient on fracture table and do the job. However, pushing it is a very difficult thing that I can tell now after completing the case. So I think, as it has been discussed, pulling is very important. And one more important thing that I realized, that putting a single pin do not give you rotational control. So if we put two pins simultaneously, then we do get a rotational control over the fragment to gently try to persuade it out of the joint, and that way it make easier. So I tried to do the stopa approach first and try to push it out, but it did not occur to me. So I added some Smith Peterson, try to go into the fracture, pull two finger and try to pull it out. It got pulled, and then I completed the acetabular fixation, and then went ahead. The another trauma team came, and they completed the proximal femoral fixation with the DHS and this thing, and that was the post-op X-ray for the patient, and that is at the end of 1 year. Luckily, he didn't go into AVN and everything united. However, there is a little bit of heterotropic ossification that is occurring over here. So, what is your protocol for HO prevention, Tulsa?
No protocol. Copious lavage intraoperatively and remove whatever the flimsy muscle which is there. So if there is any that is number one. Number two, that is what is necessary. Endomethacin is not helpful. If I think that I have to give prophylaxis, then I give 700 centigrade single radiation dose post-operatively by 5th day. But I don't give endomethacin.
Literature says that it is the gluteus minimus which is the causative factor for the HO. So you have to mercilessly go and debride the gluteus minimus. I mean, I have no experience with that.
So this
simple thing is, whatever supraacetabular area, whatever the muscle is which is damaged, you just take it out, and give a lot of normal saline wash.
So in this case, basically, we are not exposed that area. So
I know. I got it.
So we really don't know. So my sir, suppose at 6 weeks X-ray, we try to see that some flakiness there or thing. Do we need to do anything? Means we are not, suppose we have started everything, but still something is going on. There's some flaky things appearing there. So
cannot help.
Anything that can be done at that point, or we just need to wait and watch?
He's offline.
Okay. So I'll
so what is your opinion? Wait and watch, or
I think
you have to give endomethacin? Do you give endomethacin after seeing this flake of bone?
I don't think so. Once the process has started, it can be stopped.
Okay.
Yeah. So I think I would give supportive treatment like local cold compresses to elevate his local symptom, but I don't think so. It can be stopped later on.
Vitamin E helps.
It helps. Okay. Okay. So I'll go on to the next case, and I think one more case, and then we'll take on to the questions. So this is a 32-year-old male. So this is the AP X-ray. He had little bit. If we see that the ischial line is broken here. These
Yes.
are his Jude X-rays. Now, sir, algorithmic approach. So how will you classify this fracture?
Go to the
So it
next
is
X-ray.
particularly
Next
kept
X-ray.
is kept particularly for you.
Posterior column, posterior wall.
Yes. So if you see as this thing that but sir, inferior pubic ramus, the obturator foramen is intact.
Yes.
So the posterior column fracture, we say that the fracture
So
line
intact.
goes into uh, the inferior pubic ramus and then it goes up like that. So since this is intact, will you still call it as a posterior column fracture?
Posterior, first X-ray. So if you see here, there is a undisplaced fracture of the ischial tuberosity.
Yeah, that's the same fracture. It goes from here going like this.
Of the posterior column is displaced. So
Yeah,
I will put
yeah.
this as a posterior column and posterior wall.
Column, posterior wall. Yes, sir. Kali, sir?
Yeah, probably I also will agree with him.
Yeah. So this is the CT scan. If you see the fracture line, it is not going into the inferior pubic ramus. It is stopping short. The obturator ring is intact. It is going here, and from here it is going up like this. So this is for the delicate sake. So now we can see that these are differences of opinion between me and the rest of the panelists, and that is very true. Is just because this is something called as a transitional form. So this fracture falls into the transition between the a very massive posterior wall to a small kind of a posterior column fracture. So if we see by definition, if the posterior inferior ring is intact, then it cannot be a column. It's basically the column fracture needs to go down. So the fracture, the entire posterior column needs to be separated from the sciatic buttress. However, here the inferior pubic ramus continuity is maintained here. So by definition, it can fall into posterior wall or a very massive extended massive posterior wall. However, this fracture will behave just like a posterior column. So we can put it into the posterior column group as well. So this is a transitional kind of a fracture. Kulkarni sir, what would be your plan to go for this fracture in the sequence? Is he online?
Yeah,
Hello?
yeah. So I would
Yes, sir.
consider going Cocker-Langenbeck approach for this one,
Yes, sir.
this fracture. Um, the standard treatment would be to reduce the posterior column fracture first. And here there is mainly rotational element of the superior part of that fracture. So that needs to be reduced and temporarily stabilized. Either use a lag screw to fix it, but most probably use a small plate to fix the posterior column. The posterior wall again is comminuted. Here I would consider using a spring plate fixation for that, those fragments, remove any intra-articular pieces, make sure that you have seen the standard 2D scan to rule out any marginal impaction. If it is there, you reduce and fix it as well. And then use a posterior column plate. And the inferior part of the fracture could be stabilized with the screws which go into the ischium anyway. So I think it should be the standard posterior column, posterior wall.
So I think the same fracture, same way it was being treated. The small posterior column fracture was fixed with a small plate, and the posterior wall was fixed with the buttress plate like this. And as sir has said, the screws has been passed through the intact part of the ischium so that they are crossing the fracture so as to stabilize. Again, we see that there are no screws here. All the screws are directed away. Kali sir, any comment on this? Hello, Kali
No,
sir,
my
okay.
only comment was from your initial classification. See, there is a transverse element in the near the sciatic notch. The whole wall is transversely fractured.
Yeah.
So, the column.
Yeah.
Go to the 3D. Yeah, you go
from
to
here.
from there up to the head.
Yeah,
So this comes under a posterior column first.
Yes.
yeah, yeah.
And
So
then the posterior wall is a different entity, which all
yeah.
will agree. But you cannot say that this is purely posterior wall fracture. This is a posterior column fracture.
Mhm. So this is basically, as I said, sir, it's absolutely apt to call it as a posterior column. I just say that by definition, if you say by definition has been described, it is the posterior column has to start and the obturator ring needs to be broken to call it as a posterior wall. The entire ischium needs to be separated from the sciatic buttress. However, since some part of the ischium is still maintained here, it is, just for nomenclature sake, falls into the extended posterior wall, but it's very apt to treat it like a posterior column, as we have
Column
agreed.
fracture. Yeah, yeah,
Yeah.
yeah.
That's how it is fixed. So this patient, 3 months post-op, and I think Kulkarni sir is there now, so I can ask the same question to him. I think which we missed while he went offline. So at 3 months, sir, this patient has this flakiness that he's been seeing. He has some local warm kind of thing. So can anything be done at this point?
At 3 months, I think the process of heterotopic ossification would have been already established.
Yes.
So I would be very reluctant, but at this stage, you could give him one shot of um, radiation therapy, as Atul has mentioned.
Yeah.
Mahesh, one
Yeah.
question is, see, from a cotton wool appearance, this is now becoming into a really demarcated, well-formed HO.
Yeah.
Is there a role of radiation at this stage when it is practically well-formed and now becoming cold?
Yeah, there was some warmth, as
Yeah.
Pradeep has
Okay.
mentioned.
Yeah.
So
Okay.
there
There
is
was
not going
some
to be any harm of trying it,
trying it.
because we're not going to go in there to do anything else either.
Yeah.
Right.
And because the wound is healed, there is no risk of any damage to
Okay.
the wound or infection setting in at this stage as well. So maybe one try, but scientifically, I'm not sure how much it's going to help him.
Yeah. So I think that is the current area, because we all talk about prophylaxis and treatment at the end. With never it has been discussed at the intermediate stage what can be done, and the literature regarding this is lacking to a great extent. So of course, as sir said, there is no harm in going radiation, as all the drawbacks are really not a drawback right now because the wound and everything has healed. So coming to the next case, and now this is a 82-year-old female. She had a trivial fall at home, and this is her picture right now. She's a 82-year-old female. Atul sir, yes.
There was a
If appears transverse fracture, if obturator ring is intact.
Uh, the fracture is incomplete here. It is stopping somewhere. Stop here. It's not going into the sciatic notch. So it is going here. It's stopping here. It's not going into the sciatic notch.
Any other view? Posterior view?
No, unfortunately, this is the cola that is made. So these are the views which are, but it is intact. Posterior view is intact. You need to
call it transverse fracture.
Mhm.
I'm not able to see the break in the ilioischial line.
Yeah.
No, I was thinking it is whether it is a transverse fracture.
No, it's not a transverse fracture. It's the entire fracture line is here. All the fracture lines are as it has seen here. So you can see that this is an entire wall and incomplete quadrilateral plate fracture.
Correct.
But if we see, means can we see the demarcating differences in the
Visualization.
acetabulo and femoral alignment here and here? Kali sir, can you elaborate on this?
See, if you compare both the X-rays, on the left side, normal side, and on the affected side, the head appears to have migrated inside. Yeah, there, draw that line, correct. So probably this is one variety which is a pure quadrilateral plate fracture.
No, anterior wall is
Anterior wall is also
Okay,
fractured.
but it is incomplete. It is, yeah, anterior wall also is there. Agreed. Yeah.
Yeah. And if you see the parallelism of the femoral head to cartilage here,
flat here.
yeah, it is almost flat. So the sourcil, the angle the sourcil sustained here has become actually the sourcil is directing upward like this.
Yeah.
So so it's like small multiple fractures. It's a typical fracture of the elderly, where one fracture doesn't occur. The bones somehow, there are small multiple insufficiency kind of fractures happen, and the head tends to go inside like that.
This is a real big gray area now, Pradeep.
Yes, sir.
Now, the question here is there are three things you can do. Either leave it alone with traction and see how this lady behaves. If she continues to have pain in the long term, you could give her one operation of a total hip replacement at 82.
Yes.
Second modality of treatment is consider anatomic reduction internal fixation by using either a modified stopper approach or combined with the lateral window, but you probably get away with a stopper approach here, and fix that fracture, reduce that marginal impaction if it is present in the dome, and get the hip back in place. Now, my concern with such an aggressive approach for an 82-year-old is, do we have long-term follow-up data of these fixations in elderly geriatric population?
Yeah.
And the third option is, if there is damage on the 2D CT scan on the femoral head, or if there are abrasions on the femoral head, which is going to make this into a poor prognostic fracture, whether you should give them one operation and do a total hip replacement with the problem is not going to be on the femoral side, only on the acetabulum side. So one needs to be experienced in dealing with that by either using a system which allows you to get enough fixation into the columns to give you a stable construct so that this patient can be mobilized very rapidly. So there are three varieties. I would judge that patient, their fitness, their physiology, and then decide which way we need to go. Because I personally don't think we have 2-year, 4-year, 5-year follow-up of these geriatric patients with anatomic reduction using any of the fixation methods. You correct me if I'm wrong.
I
No,
think
Mahesh, I only want to ask you one question. If you compare the STOPA approach vis-a-vis a THR, at 82, probably I would rate STOPA a much simpler. And okay, let us accept she will develop AV and OA. It will take another 4 or 5 years for her to develop that. But THR would be definitely a bigger surgery from point of her thing. My experience in THR in acetabulum is not very high. I would probably still go and fix it because I'm not accustomed to do THR in acute acetabulum.
So the only consideration, Dr. Kare, is to try and minimize the operative interventions in such an elderly patient.
yes.
And
So
also to mobilize them faster, because if we operate on them and don't mobilize them, it's a double whammy of a big operation and no mobilization, which creates problems. So it's a tricky question. I don't think we have found an answer as yet, a conclusive answer with these group of patients.
I think it has been aptly said by you, sir, because there is no literature on this as of now, because the dome impaction and this thing has been given importance since say 2010 or something like that, and that too in a normal quality of acetabular patient, means young patients. And initially, all these dome infection were supposed to have very poor prognosis, but after that article has come, many more and more people are trying to salvage the femoral head by doing reconstruction and this thing, and still the long-term data has to come, because all the reconstruction has been started in last decade only. So long-term data is still need to come. However, what we know is that conserving this patient can lead to problem, because we have seen many cases in our group discussion also, so that though this fracture look innocuous at the presentation, if we treat them conservatively, the entire acetabulum goes, balloons like that, and the head goes medially, and then head locks there. Then we can have neck fracture later on because of the stiffness, and that can create problem. So conserving definitely is just because of our anecdotal collective experience of anecdotal cases, we know that the conservative can be a problem. So question remains whether to fix it or do a acute THR. I think so.
Probably I would fix it.
So this patient, again, same things were discussed, and we had took a chance by fixing, try to fix it. Took a stopa approach, try to reduce the dome impaction, try to gently persuade the bone back into its curvature. So all the horizontal thing gently was, try to persuade it back into its position. Buttress K wire and buttress screw was passed. So that's the stopa approach. Through this interval, we went and tried to persuade it back, and suprainfrapectinal place was passed through a STOPA approach, and we were able to get the normal contour of the acetabulum back with a buttress screw there, and that is the pre-op lateral medialized X-ray, and that is the post-op lateralized X-ray. This is how it has been seen. Now that's the pre-op and post-op, and this is at the union at around this X-ray is around 6 to 8 weeks, and the patient is walking is at around, I think, 8 to 9 months. She was this video is 8 to 9 months. So luckily in this case we were able to salvage the hip, but as Kulkarni sir said, we still don't have answer, how each case will behave. Anecdotal, this patient we were able to salvage the hip. So once it has been salvaged, nothing like that, but we don't know whether we can reproduce the same result in the next patient also. So it is still in a kind of a experimental basis where we need to discuss both the plans with the patient. Any comments on this?
No, looks excellent, Pradeep.
Yes, sir.
If this is the result we can provide, then obviously this is the treatment of choice.
Absolutely.
But it again depends on the surgical expertise, the damage to the femoral head, how long was the head left in medialized with damage to the head itself. So all these factors will come into play when making that decision. But this is an excellent fixation.
So
No,
I think
the most important thing was not the buttressing the plate, but the anterometal impaction that was there. That was
Yeah.
the most important thing.
So I think we have come to the end of this session on the this thing. So any final remarks we can give, Dr. Atul sir? Can you just conclude the session by giving us the summary of what we have discussed in a nutshell?
Yeah. So about this case, first of all, this
entire,
case.
yeah, yes.
Okay. So entirely, first of all, you have to know what are the column concepts of acetabulum, the anterior, posterior pillars, the walls, and the 5 types, basic 5 types of advanced. How to classify depending on the X-ray with various lines, obturator ring, spur sign, and then choosing your approach. This is what for a basic person to begin with. And then as it grows further and further, when the situation comes like such patients, 82 years old, you have all 3 options: conservative option, fixation approach, and at this age, total hip replacement if demanding patient wants single surgery, that is also one option. So put it across all the options to the patients and choose one.
Thank you very much, sir. I thank Mahesh Kulkarni, sir, Dinesh Kale, sir, my friend Sandeep, Atul Patil, sir, to be here and take valuable time out of this. I would request Dr. Ajit Shinde, sir, to give concluding remarks where before we can stop. And also, I would like to announce that at the same time, next week we're going to discuss the most important thing, the associated fracture. Though the elemental fracture seem to be very simple, but the more common fractures are actually the associated fractures. So initially we tend to get more associated fracture more often in our practice than getting these pure elementary fractures. So next week we're going to discuss that, and I will hand it over to Dr. Ajit Shinde.
Good evening, friends. It has been a very fruitful discussion of elementary fracture acetabulum by today's present experts, right from details regarding anatomical and radiological classification of the fractures and highlighted definite management of different patterns of fracture. Thank you very much for all of you for giving time for our MOA masterclass.
Thank you, sir. So we meet next week, same time.
And next week our topic is
Associated fracture.
associated